Welcome to the Alex Salmond Show from Scotland, where we return our focus once more to the dominating issue of the day. Now, Professor Hugh Montgomery of University College London appeared on our show a few weeks ago and had a tremendous response due to his mastery of the theory of coronavirus and the practical impacts of COVID-19. Today, Professor Montgomery returns to the show to discuss with us the personal impact on the healthcare professionals involved in fighting the COVID-19 pandemic.
We had fewer staff because people had to self-isolate, had to look after loved ones, had been off sick themselves. With that increased workload, which amounts to the equivalent of an extra 1.3 million person hours of work a week, or the equivalent of running an extra 126 intensive care units round the clock. That's been a very, very big burden on everybody, emotionally very hard. And we're now told from the surveys that around 1 in 2 people, as a result of that, are facing some form of psychological morbidity or distress as a result. So yes, it's been a hard hit.
All of that coming up later on in the show. But first, your tweets, emails and messages in response to our show last week on the subject of long COVID, featuring Professor Danny Altman of Imperial College London and Dr Natalie McDermott of King's College London. Joe says, thanks for bringing up the elephant in the room of long COVID. The British medical establishment's whole approach and treatment of chronically ill disabled people with post-viral conditions such as ME over the decades has been nothing short of a medical scandal. Mary says, on long COVID, can we have the facts and stats, please? If one becomes seriously ill, it can take weeks or months to reach full recovery post any disease, and that is a fact. Mary says in response, but it's only been around for over a year. Give science a chance to study it. Norma says, almost everyone I know has been vaccinated at least once. No side effects with either AstraZeneca or any others. Slight foggy feeling the next day, that's all. Bit of a sore arm, but totally worth it. Christopher says, lots of diseases have the potential to make you tired and sick for a decade or more. COVID isn't anything special in that regard. Pat says, remember that many of us were never tested in the beginning. I contracted COVID-19 in February 2020. There were no tests, and then when tests came, you couldn't have one unless you'd come back from China or Italy. We were very much on our own with it. And finally, Fiona Nelson says, good programme. Long COVID will be a problem in the future. And now over to Alex, who's in conversation with Professor Hugh Montgomery.
Hugh Montgomery, this has been a year like none other for just about everybody on the planet. But for the caring services, and those in the National Health Service, and particularly those in intensive care, the pressures must have been extraordinary over the last year. Tell us a bit about what it's been like.
So you're absolutely right. This has been a year like no other. And of course, we have to remember that everyone has had a terrible year. People have lost loved ones, lost jobs, their businesses have gone bust, they've had homeschooling, relationship problems, and it's been difficult to defuse when when lockdown prevents you socialising or going out with people as you otherwise might. That's been compounded for NHS workers because they faced all of those stresses, but also enormous pressure at work. Now, putting that in context, in wave 1, we had 11,000 intensive care patients coming in with COVID, with a disease we didn't actually at that point understand at all. So colossal pressures on those staff, a lot of death, a lot of difficult circumstances, PPE, families not able to come in. And in this most recent wave, we've had nearly 24,000 people coming through. Now, we had fewer staff because people had to self-isolate, had to look after loved ones, had been off sick themselves. With that increased workload, which amounts to the equivalent of an extra 1.3 million person hours of work a week, or the equivalent of running an extra 126 intensive care units round the clock. That's been a very, very big burden on everybody, emotionally very hard. And we're now told from the surveys that around 1 in 2 people, as a result of that, are facing some form of psychological morbidity or distress as a result. So yes, it's been a hard hit.
So people in intensive care are obviously well-trained professionals, but even the best of training surely had to account for what was, as you describe, a largely unknown virus. And is it that fear and uncertainty which afflicts people as human beings, even when they're doing their job professionally?
I think it did for many to start with. I wouldn't have wished this pandemic on anyone. I wouldn't want to have coronavirus. I wish no one had died from it. But from an intellectual point of view, I absolutely wanted it to happen on my watch if it happened at all, because that's what I'm trained for. And being faced with a new challenge that's difficult and not understood had, for me, some at least intellectual challenge. For the people who were nursing at the edge of the bed continuously for 12-hour shifts, uncertain of how infective this disease might be, uncertain whether they might die of the disease or take it home to their families, in those early stages of the first wave, those were very significant pressures. There was genuine concern. And my hat's off to those nursing staff, particularly for continuing to come to work day in, day out, and indeed for volunteers. We had people coming back, dental receptionists and dental nurses and paediatric nurses volunteering to put themselves in that environment. So a credit to our health service, I have to say.
Now, you referred to surveys which are showing that a third of staff have a recognisable psychological impact, a stress-related condition. I mean, how is that manifesting itself now that the vaccine programme is underway? I mean, are people reaching the point at which they can't go on, or are they still fighting to take us through this?
Well, it's wearying. People are continuing. We've got a lull at the moment. The numbers on intensive care have been dropping quite steeply in the last couple of weeks. I remember, there were nurses in tears before this second wave as we knew it was about to hit, saying, I just don't know if I can do it again. They did. How they would cope with a third wave, I really don't know. And I'm certainly aware nationally that there are a lot of senior nursing staff reporting that they're really considering leaving that profession in intensive care, moving to community nursing jobs, palliative care jobs, things that aren't quite as battering frontline. And you ask how people present. I do know of people nationally with, I suppose, what you call PTSD, people constantly hearing recurring beeps and alarms, keeping them awake at night, feelings of guilt that they haven't done the right thing. Perhaps more worrying as well, this phenomenon known as burnout, which is more to do with no longer being able to feel. So it's important that doctors and nurses still can empathise with the patient. We need to be able to feel for you and for your family. And we have to have some barriers to that, otherwise we'll be destroyed. But those barriers have been breached a great deal with this, and that can leave people unable to empathise anymore, unable to feel for their patients. And if they bring that home to their relationships at home with their partners and children, that can be very damaging too. So that's what we're seeing with the anxiety, to a degree PTSD, and this phenomenon of burnout.
And we've all seen the pictures of patients who've come through intensive care, who've recovered and getting clapped out of the wards. How encouraging is it for the teams working in intensive care when a patient, perhaps one who was expected not to make it, actually pulls through?
It is fantastic, actually. And we had one just recently like that, a chap in his early 30s who early on we really wouldn't have thought would make it through. And of course, sometimes they're still not mentally fully recovered and able to communicate, but when they can and are aware of the milestone for themselves, it really is fantastic. Of course, it's a slightly sad thing for some intensive care people, because we might clap them off the ward with their tracheostomy in, but we rarely get to clap them out of the hospital, because that can be many, many weeks later. And it's also fair to say that a lot of patients who come through intensive care, even though we might be talking to them and they're conscious and awake for many weeks, remember nothing of it. So some of them will leave the hospital, thank goodness in many cases, without any recollection at all of ever having been on the intensive care unit. And that's sad a little bit, because I think some of our staff particularly would be lovely to have people come back and not only say the thank you, but say, I remember you, or and whatever. And Michael Rosen, one of our patients, has been very vocal in this. I'm not giving away patient confidentialities, but that's been a real fillip to the staff, because he's got the diary that the nurses filled in, and he's quoted them all, and he knows their names. He doesn't remember it, but he knows who they were and name checks them individually. And that's a very positive thing for them.
And for people watching the programme, is there something, Hugh, that they can do tangibly to help the people in the front line who've pulled through this? Is there something that we can contribute in terms of the of helping and returning some of the extraordinary efforts that have been made on the behalf of all of us?
Well, if they wish to, the Intensive Care Society is the national charity that looks after the education, training and well-being of intensive care staff. That's nurses, doctors, pharmacists, physiotherapists, everyone that's there. And we do have an appeal. Anyone who wants to put an Intensive Care Society appeal, it'll come up in Google. And those monies go, it's a charity, there's no significant overheads. And the money is really going to supporting mental health and well-being. We've got a part-time psychologist now managing for them. And also to help support education as we go forwards, because until now, the model has been that those staff who are often, particularly nurses, not well paid, working incredibly hard, have to pay for their own education in intensive care. We'd like to see that change too. So any contributions if people wish, no pressure at all. Intensive Care Society appeal, you'll find it online.
And of course, the people working in intensive care from all of the professions have got their own lives going on. I know that you encountered in the early stages of the pandemic a family tragedy. Can you tell us a bit about the loss of your son Oscar and how you managed to cope with that in addition to all the other pressures that were going on?
Well, I suppose the answer is I haven't coped at all well with it for the reasons that we've described. I mean, if something bad happens, let's think of the people, the 127,000 people who've lost a loved one. They will all be unable to get the support in the same way that I couldn't. So yes, my son was 4 months short of being 18. A fantastic intellect, he just smashed his GCSEs, great sportsman, sort of national sort of standard sevens rugby player, all-round good guy, kind to people, friends to everyone, no matter what their intellectual sporting capacity, never a bad word to say about anyone, always smiling. So a remarkable young man with a love of the ocean. That's what he wanted to do. He wanted to do oceanography and marine biology, particularly conservation. And he'd lived in the water. He and I would snorkel summer months, often for 7, 8, 9 hours of a day in the water. Very strong swimmer and desperate to get in the water. But he'd broken his hand playing rugby in November and had metalwork in his hand, so he couldn't swim at Christmas time. Then lockdown happened, and he couldn't swim again. And the moment that lockdown lifted to allow him to have a day trip to the coast, he was insistent that's what he wanted to do. So he went down to Portland. And by all accounts, a flat, calm, crystal clear sea with bright blue sky and a hot sun and hardly anyone there. And he went in and never came out. And we found his body 3 weeks later. And I think probably what had happened was that he pushed himself a little too far. He was very good at breath holding. He could hold his breath for 2 minutes easily, 2.5 minutes. But he wasn't acclimatized. He'd been off because of rugby and so forth. And I think he went and pushed his breath hold and never surfaced. So, yeah, it was a massive blow. I suppose it came for me when the major first wave was declining, so the clinical work was a little less. But it's really as I described it. I don't know if anyone ever learns to cope with something like that. I imagine one never does, but there's been no way of gathering with people. Even the funeral had to be limited. And I say, I can't cry about this as for myself because others have had it worse. I mean, people have lost their fathers and sisters and brothers and their own children too. And I'm not alone in having faced this, but it's very difficult. It's very difficult.
Hugh, I think we'll take a break for the second half of the show, but yep. that was beautifully expressed, and certainly my heart and the heart of all people watching will go out to you.
Welcome back. Alex continues his discussion with Professor Hugh Montgomery of University College London on the long-term impact of health service workers of the pandemic.
Professor Hugh Montgomery, the strength of commitment of the National Health Service and the people within it. Is it unrivaled anywhere in the world, or are there other health services that have that degree of commitment and care?
I think it's unrivaled, and it's because we're integrated. It's not to denigrate what any doctor or nurse anywhere in a poor setting or a wealthier setting will do. Everyone has pulled together like this. But the National Health Service is a national health service. We are an integrated organisation that goes to war together. And that's what we did here. And that connection made a huge difference, I think, to the medical care. And we've got to remember that no healthcare system is perfect, that everyone listening to this may well know someone who's had a bad experience with the NHS where things weren't done right. But if you look across the suite, we are the best in class for pretty much every single domain measured by the World Health Organization. And we do it at a cost that is dramatically lower than that most healthcare services expend. So it's a very good system. And remember, of course, that not a single person in this country was ever asked to show their checkbook or credit card when they fell ill with COVID, nor are they being asked to pay for their vaccine. This is a pinnacle of human civilization in many ways, the NHS, and we should cherish it and recognise it for what it is. It's been wonderful.
Well, Professor Montgomery, I'm sure your words are listened to by the various health secretaries across these islands for England, Scotland, Northern Ireland and Wales. But just imagine for a second that you managed to get them in a room and were able to tell them the biggest single lesson from an intensive care perspective that they should have learned from the pandemic to prepare for the future. What would that lesson be?
Well, as my good Northern Irish grandmother would have reminded them, that an ounce of prevention is worth a pound of cure. Let's just look at who came in here. Over 50% of our patients were morbidly obese or obese. Over 50% of our patients were in the lowest 2 quintiles of deprivation in the country. We had here not a preventable disease, this infectious disease, but the consequences of which impacted the poorest and the sickest in our society. And those sickest people had diseases that are very largely preventable. Now, the way we've approached this so far, let's just think of obesity, is to single out people who are overweight and tell them that they're lazy or they're stupid or they should just pull themselves together and eat sensibly. But the problem actually is systemic. It's we've built a society where the cheapest food is often that which is least good for us. And if I was a poor single mother or father of 4 kids, and I could buy 11 donuts for £1 in my local supermarket, you know what? I would. So we also built a transport policy where you can't walk or cycle your kids to school, where the roads are congested and polluted and so forth. So we make it hard for people. So I would say, let's invest not in intensive care, but let's invest in public health. Let's make it easy for people to be healthy. Let's make the bad foods and so forth more expensive, yes, but let's use that money to make the healthy foods cheap so that we're not taxing the poor. Let's make it easy for people to take exercise for fun. Remember when I was at school and you were, Alex, we didn't have exercise, we had games because games was fun. Let's go back to those things in sensitive community. Let's invest in public health so that when these diseases strike, we don't get so many hitting intensive care. Because bear in mind, it's about £3,000 per day per patient to look after an intensive care patient. And 41 or 42% of them, it looks like in this wave, will die. This is a very inefficient way of maintaining health. And those people who survive have a long, long haul after this too. So I would talk about that. And I would talk about the more global issues about the way we treat our planet. We have over 5,200 more coronaviruses that could jump across to humans. We have lots of other diseases, the arboviruses and the flaviviruses in jungles, for instance, around the world, all ready to jump from animals to humans. And we've had HIV coming probably from a simian virus that's done that. We've had Ebola jumping to humans. We've had bird flu, the H1N1s. We've had SARS-CoV-1. We've had MERS. We've now had SARS-CoV-2. And whilst these don't all come from planetary degradation, if we continue to farm animals in the way that we do, if we continue to have a food supply system such that we have, if we continue to put humans at increasing numbers into wild areas, forcing animals together to predate on each other that wouldn't normally do so, and humans in contact. And then if we continue with 142 people every single second boarding a jet plane, which is what was happening just pre-COVID, we will get more of these pandemics and we will spread them around the world. And no one wants to go through this again. We will, almost without question, we will. This will happen again. But we could limit the number of times that happens again if we start behaving differently. And we could limit the impacts if we address the public health issues, which, of course, remember, save the country money. They make people healthier. They make people happier. These aren't downsides. Public health is not a soft, wet side of medicine, and I to use the spangly end. The public health part is actually, you should probably fire me and put the money into public health.
Let's look at one aspect of the jumping of viruses from human to animals and back again. When we last spoke, you told us of an analysis of the coronavirus variants in the mink population in Denmark and France. Are we saying now that that sort of husbandry of minks is an actual danger to human health because of viruses like coronavirus?
Well, I would say that, yes, it is. And these issues, of course, are very poorly weighed by most people who don't separate risk and hazard. So the risk is the chance of an event happening. The hazard is the consequence if it does. Let's look at the mink farming. The risk may be low of a coronavirus jumping in, changing, being mutated and jumping out. But why would you take that risk so that someone can wear an animal's skin? It's one of those things that's anachronistic. That's an industry that just needs to stop. But there's a lot of animal husbandry that's like that too. And I'm not a killjoy. We all do things that are fun that probably aren't as good for our health as they should be. But if you think about the diet, for instance, I've moved over largely to vegetarian-based diet. Someone serves me a steak, I still eat it. I'm healthier for it. Am I less happy? Actually, no. I've found some very nice foods to eat as well. My impact on the planet is less, and my health is better, and I hope we become less of a burden on the health service. So I think there's a lot of different ways in which we could live that won't make ourselves all miserable, that we could be just as happy, if not happier.
From your academic analysis, would you say that coronavirus is one of the most dangerous viruses in the sense that it is deadly, it causes not just a mild illness, but deadly illness on the one hand, and is highly infectious in all its variants, but particularly some of the emerging ones? How unusual is that as a combination for a virus to have high infectivity with a relatively high mortality rate?
It's the problem with this virus is it's a right nuisance because it's hit a sweet spot of being highly infectious and just dangerous enough to really become a problem. If it was utterly fatal, killing 1 in 3, there'd be massive lockdowns without dissent and it'd be a different narrative. But we're in a situation where it's infective enough, very infective, but with enough people who get impacted that we have to take these actions that do appear draconian. And I get that. There's a big dialogue now, of course, isn't there, about whether lockdown is right, whether more people will suffer from the economic consequences of lockdowns or so forth. But we've got to remember that, again, the arguments are sometimes conflated. I've heard people say, and they've said to me, Hugh, it wasn't worth the lockdown and the economic hit for the sake of 126,000 lives. But of course, the lockdown wasn't for the sake of 126,000. The lockdown was for the sake of the potentially 600, 700, 800,000 who might otherwise have died without that lockdown situation. Now, is it worth the economic damage to save that many lives? Well, that's an individual judgment that people make. For me, I think it's a mark of a civilization that we protect the minority of our population. But it's not to say that there aren't people who feel differently about that. These are conversations we really do need to have nationally, because as I say, I'd love to say this is the last time this will happen. I don't think it will be. And I don't think we're out of the woods yet with this virus. You alluded to the new variant. As long as people are not immune because they're refusing the vaccine, or potentially because they're not responding properly to the vaccine, or because they can't get the vaccine. There'll be people who can get infected. And if those people are infected, in those people, the virus can mutate. And if it mutates, it can come up with variants that are less impacted by the vaccine we have, in which case this becomes a rolling problem. I think that's to some degree inevitable. There's going to be a bit of a germ warfare race going on of the vaccine developers having to keep catching up with the new variants. But people have been commenting this week, are we in for a year or two yet of social distancing and masks? I don't know, but I wouldn't be surprised if that wasn't what happened.
Professor Hugh Montgomery, for sharing your personal experience and, of course, for your academic wisdom. Thank you so much for joining me again on the Alex Salmond Show.
Thanks very much for having me, Alex.
When I last interviewed Professor Hugh Montgomery, our discussion centred on his unique position as an outstanding theoretical academic and a consultant manning the intensive care wards of a busy London hospital over the last dramatic year. Today our discussion turned to other realities. The reality of the pressure on the frontline National Health Service staff of the extraordinary conditions of pandemic. The reality that unless humankind changes our ways, then the events of the last year will not just be a bad dream, but a recurrent nightmare. If this virus is allowed to retain a grip anywhere on the planet, then there is the clear danger of it coming back in ever more virulent form. Even more concerning, unless we change the circumstances that allowed coronavirus to shift the world in its axis, then it will represent the shape of things to come. And so from Tasmina, myself and all at the show, it's goodbye for now. Stay safe. We'll see you again next time.